Hey there. Could you give me a thumbs up if you can see the slide and also hear me? Okay, great. Thank you so much. So we're gonna pick up where we left off on Monday, which was looking at uh, echocardiography using Doppler. And this is primarily used to measure the blood flow velocity. And as you can imagine, it's very useful to be able to measure the blood flow velocity if, for instance, you have valves that you're trying to determine if they are doing their job, and the blood flow is not getting through the valve when it's closed. It can also give you estimates of peak velocities in physiological places that have been stenosed or made the orifice itself has been made smaller. Say, for example, in the aorta, if it's pinched down, or in the aortic valve, it might be too small, the orifice might be too small, and that will cause a very high velocity jet of blood. And so you'll be able to see that and actually quantify the severity. So getting a quantitative estimate of what the blood velocity is helpful. You can also imagine you can look at the blood velocity signal as a function of time, integrate that to get how much blood volume is coming out of say, the left ventricle. So the principle by which this works is you broadcast the ultrasonic signal from your piezoelectric crystal, goes into the sample, reflects off surfaces in the sample. In this case, it's going to reflect off erythrocytes in the blood. And if those objects are coming towards you, the signal you will receive will be frequency shifted up, be a higher frequency that you receive than you transmitted. And if those elements are moving away from you when they make the reflection, the signal that you receive will be shifted down. And the simple formula for that is the frequency that you detect on your receiving mode is related to the frequency that you transmitted by this formula, and it's linearly proportional to the velocity of the reflector. If your transducer is at an angle with respect to the direction of the velocity, so let's say this pink thing here is the aorta and blood is flowing through the aorta in this direction, our transducer is seeing or is reflecting off, the beam is reflecting off reflectors in the aorta at this angle to the transducer. As you can imagine, if that angle goes all the way up to 90 degrees, the reflection, I'm not going to get any signal back. I'm not going to have frequency shift because the object is not moving in this direction at all, right? It's only moving in this direction. So I will get no frequency shift here. If, on the other hand, I am able to angle my transducer all the way down here, when I ping the reflector, it's coming directly at me. So it just goes as the cosine of that angle. Okay, it's fairly simple. But this can be used basically in real time on the machine to make velocity maps. And so you make a two-dimensional image and you look at the velocity shift and you map that on top of your two-dimensional image as a color. And then you see velocity. And so here's some examples. If our transducer is on up here, right? And so this is the left ventricle of the heart. You can see this kind of half of a football shape like this, or half a rugby ball, depends where you come from. And the transducer for this shot is not usually going through the ribs. It's usually positioned further down to the bottom of the rib cage, and you try and tuck it under and look up under the ribs so that you're looking at the apex of the heart. And you'll get this view. And it's a very convenient view in that this is called a two-chamber view. It has the left atrium in the view, in the field of view. It has the left ventricle and the left ventricular outflow tract. And this is the aortic valve here, and this is the mitral valve here. So what we can do is we can measure the Doppler spectrum for a specific line. If I look at my whole image, I can draw a line along one place. So I'm going to draw this line right down here and ask, what is the velocity as a function of time? Just on that single beam, and we can map that time domain signal out, right? So the velocity is showing a negative peak or spike of flow, and then it goes in the opposite direction, it goes down, and then another spike of flow here. And so that's the velocity up and down on this, basically on this beam. You select a position along that beam. We can also make a map for each voxel in this picture. When we sweep across, we'll measure the velocity for each reflector that we're going to map here, and we can color code that velocity. Red to yellow is blood that's flowing towards the transducer. This is the color code of the velocity here. So red means the velocity is coming at the transducer. Blue to green this way means it's going away from the transducer. And so you can see that in the left ventricle itself, one half of the ventricle, the blood is sort of swirling down this way. And then as it's being ejected, it shoots up this way out the aorta, right? And so we have a high velocity. That's this green signal here. And in fact, we have some red and yellow because there's probably some kind of swirling and random direction to the velocity there as it's coming out. So that's during injection. And then when we look at the velocity when the left ventricle relaxes and opens up and sucks blood back into it from the left atrium, which is here, then all of that velocity turns red because it's coming from the atrium up towards the transducer. And so you can make a nice dynamic movie of these velocities. You can do this with basically one other imaging technique, which is magnetic resonance. So in MRI, you can make an image that is proportional, linearly proportional to the velocity of the voxels at that position. MRI takes longer than echo to do that. It takes multiple heartbeats to do it, as we'll see. Echo can do it in real time. Yeah.
If they're like eating an apple and then they'll show something lights up on them. Is it the same thing? Like, is it because of the velocity?
Are you talking about functional MR?
Yeah.
Okay. So the question is this color map the same as a functional MRI color map?
Yeah.
Yeah, okay. Those are two different physical phenomena. They're caused by the underlying reason that the MRI signal changes is because the capillaries at the low level of the blood flow, they dilate, open up when you need more blood flow to a region of your brain. So for functional MR, you're not really measuring flow. You are measuring the change, essentially the change in local magnetic field strength because of the deoxygenation of the blood and the geometry of the little vessels. So, and that change in signal is usually a few percent. So it's not like this. This is just physical. How fast is that thing moving? That's what you're measuring. And so MRI can also do that. MRI can look at an aorta, for example, and say, how fast is the blood moving in the aorta? And it will give you a number. Okay, but it's different than functional MRI. Functional MRI, for whatever reason, they used a very generic term, functional. And it's like neurological activity MRI or something like that is what it really should be called, which is in itself a fascinating field. I mean, it's a huge, huge field. And that actually, functional MRI happened when I first got into MRI. Nobody was doing it when I came into MRI, and it was discovered and happened. And it was a pretty exciting time because half the people didn't believe it was true, half the people did. So there were these big scientific debates, as to whether or not it was actually a real phenomenon. And there were instances at conferences where people had posters, and it was like the functional MRI of a dead halibut, the fish, right? And so they did the experiment to this fish, and they got a positive result. And so they're like, we're thinking a lot of this is just, basically probability of random events lining up, right? And but those naysayers, those people who didn't believe it, were wrong, and the people who stuck to their guns became very famous. But nobody really knew how it was going to turn out when it first came along. So we'll look at a couple of artifacts. In this case, if you have an interface between two tissues in which you have two different velocities, okay, and that interface isn't a nice perpendicular interface, sort of parallel to the transducer so that everything would reflect back. What happens here is you're going to see an object in an incorrect position because of the refraction of the wave at that interface. And it's like light. When you look inside a glass and you say, where is the spoon? You get it wrong because of the way the light bends when it comes through the interface. And so in this case, if I have, and I'm sweeping my beam here and I look down and I get refraction at this interface so that the beam reflects back up through here, on that beam location, I say, oh, I have this object there, right? And so the image, this whole thing gets shifted across, and so that thing appears here, right? So it's picked up in the wrong location because of this refraction. I actually can't tell you how severe this artifact is. I've never done any actual quantitative tests on it. But you can imagine that for certain small things that are on one side of the heart versus fat or something, they might shift.
You just fix it mathematically.
You could if you modeled this interface and you modeled the two velocities. And so in this case, you could fix it. When this is all mixed up, right, and it's very complicated and there are many interfaces and many different velocities, all of these artifacts start adding and start looking random. And so probably what it shows up as is just a crappy image, like things on top of each other, right? So it would be hard to do the inverse problem. In this case, it would be easy, but this is just to illustrate what's happening. So the other things that happen when you look at a ultrasound image, you'll see sometimes a dark streak in the image. So this is the baseline tissue. This is, as you can see, some kind of correlated dark streak. This is a very bright streak. And so if you have a low attenuation object, the signal will get interpreted as having, low reflectance here and higher reflectance on the back. And if you have something that shadows or has high reflectance, a lot goes back, and then it underestimates the reflectivity of the stuff behind it. And so these streaks show up. They're very dynamic. So when you're holding the transducer and you're trying to find a place in the heart, these streaks are just coming and going in real time. And essentially, they learn to read through them. They just know that's an artifact. That's not an actual change in tissue that's got this correlated shape. I'm not going to call this a tumor in that shape, right? So, but you have to take all this into consideration when you're looking at things. But you can imagine, because it's real time, I'm looking at something. All I have to do is move the transducer a little bit and see if that object changes as an artifact would change versus having something that's actually in the field of view, right? That's pathology. Oh, this is an interesting one where a boundary gets displaced behind a tissue for which you have a different velocity. So you can see this boundary will be distorted because you've got a glom of a different tissue inside this beam. That's an interesting one. And that you can imagine is subtle enough that you would look and say, well, I'm going to call my boundary here. And if you were doing thickening or something like that, you probably would not have the wherewithal to correct it. Um, so this is, I'm not sure how it does the spatial resolution. So what do we got here? We've got a 2100. You know, I've forgotten what this slide is teaching us, so I'm not going to do it right now. We'll do it later. And then we've already looked at this data that in terms of the reproducibility of echocardiography is not terrific because so much of it depends on the interpretation of the human, actually. So here, let's go to 6. All right. Again, here's our transducer. I've got a nice view of the left ventricle, left atrium. I can rotate the transducer and look at different tissue. Here are the coordinates of classic views of the human heart from echocardiography. And these views also are used in nuclear medicine, MRI, and CT. So essentially, when you want to show a physician results of your imaging technique in the heart, you want to first show them those results in these views because they know these views very well. They've been looking at them for 50 years, right? So there's 3 classic views. One is called the parasternal view, and it comes from echocardiography because the transducer is on the chest wall. It's parasternal. So here's the sternum, and it's beside it here. And you're looking straight down at the heart from right above it, okay, along the ribs. And so this is the view of the human heart you've got. You've got the aorta here, right? The aortic valve here. The left atrium is here, right? And I'm gonna put this laser back on here. Huh, okay. The left ventricle is here, but it fades out as we move this way because we just run out of space in our field of view from the fan, from the echo. So we can't get all the way down to the apex with this view. We just get about a third of the way, cuts off about here. And then the right ventricular outflow tract is this hole here, okay? So this view is very useful for looking at blood flow in the aorta, blood flow through the mitral valve, and left ventricular function at the base. So you can look and see how is the muscle functioning here? How's it functioning here? Right? Is it normal? And that's called the parasternal view. We then take the transducer and move it down to the bottom of the ribs towards your feet and go under the ribs and look up, right, towards the heart. So now the transducer is here. The tip of the heart or the apex is here in the left ventricle, and the right ventricle is beside it. Right atrium, left atrium. So this is called, for obvious reasons, a 4-chamber view because I get to see all 4 chambers of the heart, or at least a slice of the heart that goes through all those 4 chambers. And I'm able to evaluate, again, the mitral valve very well and the tricuspid valve here, which is the valve between the right atrium and the right ventricle. For evaluating cardiac function in the sense of myocardial function, this is a good view because I see the entire myocardium all the way from the base valve plane all the way down to the apex. And in this view, we'll see it shorten in this direction. The valve plane will move towards the apex, and we'll be able to measure whether or not this tissue is contracting and this tissue. So I have a good view for left ventricular function in this 4-chamber view. if I rotate, so here's my transducer. All I have to do is rotate the transducer 90 degrees, approximately 90 degrees. And then what I'm going to achieve there is I'm going to cut this plane right down this axis. So I'm orthogonal to this one. And that's the two-chamber view. Reason it's called two-chamber is I'm going through the left ventricle and the left atrium. And that's what it looks like. Here's the left ventricle, here's the left atrium. And now I have two other segments of the left ventricle, this one and this one, where I can evaluate the muscle function. So now I have 1, 2, 3, 4 different segments of the left ventricle of that cone to evaluate whether or not the muscle is contracting. And I'm looking at the mitral valve again and the left atrium. So these two views are very important for just general cardiac function. How is the heart doing? You know, is it contracting well? Are the valves operating well, etc. And then this one, we get really nice, a really good look at what's going out the aorta, because in these two slices, we don't see the aorta, right? It's off to the side. You can see in this four-chamber view, if we were to tilt this just a little bit, the aorta would come off here, right? But what you do is you tilt it back so the aorta, you just miss the aorta and get this view. And we'll get the aorta over here. Okay, so looking at those views again, here's the parasternal view, was on the left, aortic outflow tract. This, again, is the two-chamber with the left ventricle and the left atrium, and the four-chamber with all four chambers. We can cut these views perpendicular this way, right? And those are going to be short axis views. And that's down here. They look like donuts. So they're also shown here as 4, 5, and 6. There's the apical, the mid, and the basal short axis. And those donuts are used to evaluate left ventricular function all the way around the left ventricle. Remember, we got a two-chamber view, which was essentially a cut this way. And we got a four-chamber view, which was essentially a cut this way. But now we get to see the entire thing and connect those functional patterns at the base, the mid, and the apex of the heart. So I think, I might have, you should know these labels, okay? It looks like a lot of words, but it's actually not. There's only sort of 4 basic words. You have the apex, the mid, and the base. So that's one axis, right? And then around the heart, you have anterior anterior lateral over here, inferior, which is the bottom. The patient's back is down here, and then the septum over here, but the anterior and inferior septum. These chunks, as you can see, there's 6 chunks there, right? We don't cut it into 30 chunks because usually you don't need that type of resolution to report an abnormality. So if we're looking at the echocardiography views, and you will see all of these in the report, these will be beating, these will be beating, and you see something, part of the muscle is very thin and not functioning very well, and part of the reason for that is it may have suffered a heart attack some time ago, it's now fibrosed, and the wall has thinned, and you want to report that. You basically, the coordinates you use are these. You say the anterior wall of the heart has been thinned, or you say the anterior and anterior septal, and that tells you this whole chunk is thinned and not functioning, right? That's how you report that out. This resolution is fine for that type of clinical report, and it comes out of, I think, nuclear medicine, because this is actually the spatial resolution of nuclear medicine imaging. That's kind of, the signal comes in big chunks like this. It's low resolution. With CT and MRI, you get much higher resolution. And so usually you'll take this as the basic mapping, but inside that you can do subdivisions, right? And normally when we look at the heart now quantitatively, we'll have 5 different levels from the apex to base through the ventricle. So we'll divide it into 5 or 6 different levels on that long axis view. And then around we'll usually use, 12 to 18 angles, something like that. And that way you can make a very nice map, of the colors of function. When we're looking at the short axis views in the heart with echo, normally the transducer is sitting in the same place you would get the parasternal view, but you rotate it 90 degrees, right? So remember, if I took this and I spun it 90 degrees, I would now be looking at a long axis view, which would be perhaps a 2-chamber view or a parasternal view. It's usually the parasternal view because the thing's up here. But then I can just tilt it. I take it and tilt, and I see different. I see a short axis view here through the mid ventricle. I see a short axis view here through the base of the heart. And then this is all the way up into the valve plane, right? So I have the left atrium, right atrium, and all of this, the right ventricle up here, the pulmonary artery. And that you just do in real time. But then when you want to record function, you just stop, put your foot down, or touch a button, and it records a few beats, and then that goes into the report. And the physician will read that out. And this is what it looks like when you're looking at the echo machine. So here's my transducer on the patient's chest. This is that short axis view we were looking at here. Looks like this, right? So this is it here. We don't really see the RV here. But then down the red, if I rotate 90 degrees and I take the plane that goes down through the red, it looks like this. And this is that parasternal view. Here's the aortic outflow. This is the top of the left ventricle on the septal side. And then this is the free wall, or what we're calling it here. We're calling it the anterior lateral wall. Okay, so this is the lateral wall down here. And left atrium. And then if I tilt towards the right ventricular outflow tract, I can see that, right, during systole, I can see the flow out of the right ventricle, right, towards the pulmonary artery. And then if I tilt towards the right side here, what am I seeing here? This looks like, I don't know what I'm seeing here. The medial to the parasternal. This is not a traditional view. So you see what I mean? It's quite confusing. Like, what is over here? And where? This is probably atrium, right? Yeah. Okay. So to look at, we talked about this before. If you want to really look at some beautiful pictures of these things, then you should go to GE Healthcare, Siemens, Canon, who else? I'm missing a big one, I guess, but Philips. And they all have fantastic sites. And just go type in ultrasound. This used to be a great site, this one here, and I checked it this morning and it's gone now. So they've changed it to this site here. So I'll change the slides in the thing such that this is updated. But you can just Google search Siemens ultrasound and you'll wind up here. So this is that site. This is their new Acuson site here. And I think, I might have put, oh yeah, here it is. It's this site here. And, it has all of these dynamic things. So this is looking at, real-time 4D imaging with Doppler put on top of it, right? In real time, which is pretty crazy. I think we can come down here and look at some of these. So we looked at that one before. So here's a classic Doppler shot where the blood is going up. So this is left ventricle here, right? I don't know what that said. So this is the left ventricle here and the left atrium. And you can see the blood is going into the left ventricle when it relaxes, but it's also creating a huge jet away from the left ventricle during contraction. So when the left ventricular muscle contracts, there's a hole or something in this valve, and the velocity is coming out here, right? And so instantly you know what the pathology is, and you know the severity of the pathology. And this one looks pretty severe, right? So the problem with this is you're going to get very tired, right? Because your heart's going to be pushing half of the blood it ejects in the wrong direction. It's pushing it back from whence it came. And so it's just work that doesn't achieve anything. And so this can lead to, as you can see, the ventricle just pooping out, right? It's just like it's working too hard. Let's see what else we have here. Oh, this is gorgeous. So here you can see, well, one thing that's clear here. So if my transducer's up here, I'm not actually sure where this transducer is because I believe this is a intracardiac catheter in focus. Maybe it might not be. So I have a transducer here anyway, whether or not it's inside the heart or in the esophagus or on the patient's chest, but it's probably in the esophagus. As we look down at the edges here, you see the super sharp delineation here, very, very clear. And then as you get farther and farther down, you can see that it gets blurrier, right? And this is what we were talking about. Oh gosh, you guys got to tell me that that's on camera. Jeez. Just looking right to the graph. Okay. Um, and so, yeah, you can see that there's a extra blur all over here, and that's that depth in the signal to noise and spatial resolution. That probably the optimal spatial resolution is right about here in both the slice direction and in the lateral direction. And this is a gorgeous picture of the aorta, right? And the aortic valve opening and closing nicely. And then this is the mitral valve that is being held together by some kind of device, right? And it's pretty cool that you can visualize it so well. This is left atrial appendage visualization. We'll look at another case of this actually in a second, so we don't have to pause there. Wow, look at that. This is an ICE catheter, which means that the catheter is actually intracardiac. So it's a wire with an ultrasound transducer on the end of the wire, and you push it up and put it into the heart volume and look around with it. And these are the type of images you get. This is likely an ablation catheter, which has been also put into the heart, and we're going to touch the wall of the myocardium and inject either RF energy, see that, to heat it, to heat the tissue, to cook the tissue. And that's the way you treat certain arrhythmias. If the heart has constant arrhythmia, and so you're in atrial fibrillation, you can put a catheter on the tissue that's causing the aberrant excitation, and you kill that tissue, and then that excitation goes away, and you're back into sinus rhythm. It's a very important thing to do. And then, oh, this is another ICE catheter. Look at the clarity of this. This is obviously a wire for the ablation. And this, yeah, look, see how it clicks up there. That's really cool. Let's see what else we have. These are contrast beads, okay, that have been injected to cause the blood to go really bright so that you can measure function. I think we looked at this. This is the transesophageal echo lead, and then this person is injecting with this they're injecting something. It looks to me like that's a needle catheter, and so they're injecting something in there. Let's see, transfer. Yeah, precise guidance of they're injecting. Sometimes if you want to ablate something, you can inject a toxin into it locally, and that will also kill the tissue. And so you just need a needle and you inject that. And you can imagine that certain types of cancer therapy, for example, if you have tumors, you can put needles and inject a toxin and watch in real time just to make sure you covered the tumor with the injection. Here, okay, so this is automatically, so you click on the heart and you just say, give me the boundaries of the heart, and it will look at multiple views and then draw these boundaries to get the volumes. And then this is dynamic imaging. And so you can see that this is the left ventricle, obviously. It's quite blurry, right? So something happened here. Why are the images so crappy? And what happened was this ultrasound data is being taken in 4D. So it's, remember we said we had about 2,000 views a second? It's dividing up all of those views to collect the entire volume, right, at a certain temporal resolution. And so it has to sacrifice something, and it's sacrificing spatial resolution because it's not sampling clearly. So, however, if what you want to see is real-time ventricular function, it's pretty good, right? So you get this volume and it shows you what is happening to the volume in real time, right? Excuse me. These are segmental evaluation of how the muscle tissue is contracting. So this is tissue shortening or muscle tissue shortening. Let me zoom this up a little bit here. And what we're going to measure is, say, the length of the yellow line and the length of the green line, etc. And we'll plot those lengths as a function of time. And so you can see over time, they stretch a little first, and then they get shorter, right? And then it relaxes back to their baseline length, and then they stretch and get shorter. And so this rate of shortening down here and how much shortening we actually achieve at each point on the left ventricle is classic myocardial function. So you ask, in a normal person, how much shorter does this yellow line get after it's finished contracting? So when I've ejected all the blood, how much shorter does it get? And so you can see there's a reproducible way. The heart is remarkably reproducible. If the rhythm stays the same and the patient holds their breath quietly, the heart can achieve the same beat to within a millimeter over and over and over. It's amazingly reproducible. And that's why any of these things work when you use multiple heartbeats. Even the flow in the ventricle, when you see it, it can have a very random looking, like when the mitral valve opens and the flow goes down into the left ventricle and it refills, it goes down at a certain angle and it hits the apex and then swirls around, right? So it's a flow you would imagine is kind of random. It should have random components. But when you actually do a velocity map and you use like 30 heartbeats to look at that flow field, you actually get a coherent result. So that flow field actually reproduced itself about 30 times, right? It's surprisingly reproducible. Obviously there are certain times when if you have a really tight stenosis and it's just a jet of flow, then that's all going to be a random turbulent flow coming out of the jet. But for the most part, in the flow rates and the viscosity and everything about the blood makes it exceptionally reproducible from beat to beat. So this is a functional map over time. And MRI is really good at that. We'll see that with MRI, you can do this type of functional map, but make these elements not a big long yellow thing on one half of the septum. You can make it literally a 3 mm box and see how the heart is functioning on that level. So again, color Doppler, you can see now you're experts, right? So we see the red, the flow is going towards the transducer that's up here. And then the bad news is this, right, is blue shooting the wrong way through the valve, okay? You can measure that precisely by looking at the signal itself, and we looked at that briefly before. You can trace out these patterns of velocity and get very quantitative estimates of that velocity. Don't know what that is. Again, this is something that's fairly new. I mean, it's been around for maybe 5 years, but that's a 3D or a 4D, right? This is a 4D image in that it's 3 dimensions, 3D voxels over time. So it's like 4D CT. This is what a slice through it looks like, looking at this valve shutting. And then you can also map on top of that these, Doppler velocities, and then map that into the 4D to see exactly where stuff is squirting back through, right? Or up here where it's squirting back through. This is pretty amazing, right? That's pretty good. That you can do this with a transducer you just put on their chest and make this image. So kudos to the echo engineers who made all of this possible. Again, that's Doppler in any 3D orientation. Again, the Doppler coming through what looks like a valve that cannot close. And here it is with the device in there. And we already looked at that. Okay. So I'm going to go back out of here. Go back to, I think okay. Again, we already looked at an example like this where we see velocity in 2 directions. Here's a parasternal view. So this, remember, now you should be getting used to it. It's like, okay, there's the aorta, there's the left atrium, this is the left ventricle, this is the right ventricle or the right ventricular outflow tract. What I can do is make measurements of the dimension of the left ventricle at end diastole, the dimension at end systole, and look at the function of the ventricle, and then do an M mode through there. And this is what the M mode looks like. Do you remember what an M mode image was from last lecture? Let's pause. So remember, I have one line that I'm measuring, but I can measure it with ridiculously high temporal resolution. So, and then I plot the echoes from that one line as a function of time. And so here's the EKG kicking off, and I see the ventricle basically getting smaller. So this wall goes down like this wall goes like that. I look up here, it's this wall and this wall. So they're coming together, right? And you can measure precisely how fast they're coming together to get an idea of what's the, rate of strain of that. And then you can repeat that over time. So that's called M mode. And you can do a lot of quantitative estimates of what's going on with M mode. And then we have measurements of the valve leaflets themselves and how fast they're moving. So there's lots of, every ecosystem has all of these quantitative algorithms that are just available on the workstation that you can look at data. And here, this is, again, looking at the volume. Excuse me. Okay. This is 4D data. This is from a few years ago, this one, but you saw from the recent Siemens data, it's getting even better. And now this, we want to look at flow in the left atrial appendage. Here's the mitral valve. This is the left atrium up here. The left ventricle is down here, mitral valve. And then there's this pocket that comes off of the left atrium. It's called the left atrial appendage. It's right here. That, for people who are in atrial fibrillation, that little pocket tends not to empty. So blood goes in there and it stays in there for a long time, right? We'll see a very good CT description of the shape of this chamber. And what you want to do is evaluate whether or not there is a thrombus inside the left atrial appendage. Excuse me. And I think I might have a picture. So we can do a Doppler line through here at the left atrial appendage and ask the question, does blood flow go in and out of the left atrial appendage? And here's a picture of this. Again, this is the left atrium up here, left ventricle down here, and the appendage comes off the left atrium. And this is a frozen time frame. And you can see this signal here. It doesn't look like regular blood. Neither does this really. This looks like blood that has been slowed down a lot. They call this smoke on echocardiography when you're looking at something and you see a little puff of reflection, and it means the blood has come to a momentary standstill or the velocities has become smaller. And then this object inside the left atrial appendage is, in fact, a thrombus. And so thrombus is when the blood clots and it becomes a sticky, gooey mess of, like it can be small, like a few millimeters across. It can be big. It can be up to centimeters across. And it's just a clot, a blood clot. And so when people are in atrial fibrillation, they're suffering from the fact that their heart can't really adjust its heart rate appropriate to needs. And so when they walk up the stairs or whatever, they get very uncomfortable. And it also feels weird to have your heart beating in a random way and you get a little lightheaded. So the way you can treat it, atrial fibrillation, as like millions of people are in atrial fibrillation, the way you can treat it is either with drugs or you take them to the hospital and you put electrical paddles on their chest and boom, you pop them with a very high voltage. It's called defibrillation. And you've seen that on many medical TV shows. It's a very dramatic moment where they clear, boom, and they pop the patient. So that puts a huge voltage across the whole heart, and it basically clears the random voltage that was there during the fibrillation. And ideally what happens is the natural rhythm of the heart just comes back, overrides that random one that was there because you've cleaned it all off. So the heart starts to contract and the left atrium starts to contract and the left atrial appendage starts to contract after you do that defibrillator. The problem is if there is a thrombus in the left atrial appendage and you do this defibrillation of the patient, that thrombus has a very high probability of getting squished out of there and it is now on the left side of the heart. So it's now, it gets squished out of there into the left atrium. It slides down into the left ventricle. And now the trouble really begins. It now goes up the aorta, right? So there's this little clot and it goes up the aorta, over the aortic arch. And if you're terribly unlucky, it goes up one of the carotid arteries, right? And then it goes up there and lodges and you have a big stroke. Okay. So that form of stroke is apparently about 75% of strokes that occur in people with atrial fibrillation. The stroke comes from the left atrial appendage clot, right? So this is where image quality really matters, right? So it's like, what is the downside of my image producing a false negative? I remember they all seem kind of sort of up in the clouds. I got a false positive, true positive, false negative, true negative. And I got all these statistics. It didn't seem like it really meant anything to any human. A false negative for this human is a big deal because you missed it. So you say, oh, I don't think there's a clot in the left atrial appendage because your spatial resolution isn't enough, your time resolution isn't enough, or whatever. And then they defibrillate that patient and they have a stroke. Okay. Huge sort of penalty for a false negative there. What's the penalty for a false positive? So false positive means somehow the signal gives an indication that there is a clot in there when there isn't one, right? And basically the patient is scared and the physicians go, oh, we got to take this serious because we have a clot. And so what they do is they don't defibrillate the patient. They leave them in AFib and they give them a drug that dissolves clots. And that takes about a week. And they bring that patient back and look and see if the clot has been dissolved. Well, in this case, the clot will have been dissolved because it was never there, right? Because it was a false positive. So you put the patient on a drug for a week. If everything goes wrong, they're on a drug that thins your blood and they fall down the stairs and they have a massive bleed, right? Internal bleeding. Or they're an elderly patient that is susceptible to bleeds in their brain or other parts in their body, and then they suffer from that. That's the downside of a false positive. So now you have those statistics. Remember back, we had his distribution like this, one distribution like this. We said, oh, we'll put our threshold here, blah, blah, blah. But now, when you make that box, the 2x2 box, it's called the confusion matrix. When you make that box, you also have to take into consideration what happens to the patient when I put the patient in that box. And what are the risks associated with being in that box? And that can sometimes significantly skew where you put that line to put people in the true positive box or the negative box. Okay. This is a CT image of the blood pool of the left ventricle and the left atrium and the aorta. Okay, so these are the features here. We looked at this movie once before, I think. Look at this guy right here. That is the left atrial appendage. Okay, let me pause and I'll try and drive it so that we see it. There it is. Okay, so here it is, full of blood. It comes off the left atrium. Blood comes through a little orifice here into this thing. What the heck is it doing there? Right? It's strange, right? I think the basic, you can clip it off and you're fine, right? You can just like take it off, stitch up, and you're good. But I think what happens, if I was to guess what it does, it's like a baffle for pressure reduction. So if you have, for some reason, your left atrium's under high pressure, this thing can dilate and take some of that pressure away, right? It's my guess.
previous time you said like there's a blood clot, then I mean, even if you defibrillate the person, but you don't really know the cause for the clot in the first place, right? What if it happens again? Like you clear it, or like you.
Oh, okay. That's a great question. So let's say we have a positive, we can even have a true positive clot in the left atrial appendage, and we put the person on drugs. And then they come back, we do a spectacular job imaging their left atrial appendage, nothing in there. We say, fantastic. They go upstairs, defibrillate them, and then an hour later they have a stroke. It didn't necessarily come from the left atrial appendage. It could have come from many other places. However, the statistics of the situation when they've looked at it retrospectively for 20 years of people who've had strokes, they're called cardiogenic strokes. The clot came from the heart, right? And normally the way you associate that is that that person had a history of having clots in the heart, or later on they have another one and they have a clot in the heart. So you see whether or not they have a why is there? Oh, that's a very good question. So the question is, why would you get a clot in the first place? Why do you get thrombus in the first place? Often, this is a guess, okay? It's like an educated guess, is that there are places and geometries in the heart where the blood, for whatever reason, slows down and gets stuck in a sort of static configuration. And so it'll sit there in a very slow moving configuration. And during that period, that's when the clot starts forming. Once it starts, I think it's basically a cascade of events that keeps it going. But most people would say it is a geometric fluid mechanics problem, in that there's a little spot, and this can happen at the tip of your left ventricle, right? You can look at the flow map in the left ventricle, and for whatever reason, there's like maybe it's kind of prolate because there's damage to the wall. There'll be a spot where the blood comes down and just kind of misses it, right? And it's very idle in that spot. And so that's the problem. If you have blood in a test tube and you keep rotating the test tube back and forth like this, it takes a lot longer to clot. It may never clot than if you stop and just let it sit there statically. It will clot, right? So one way to make blood clot is just to stop it, right, from moving. So when you don't have that shear between anything inside the blood, then it clots up, which is a good thing when you have a cut. You don't want to keep bleeding, right? You need to start it clotting, right? So here is the left atrial appendage. You can measure whether or not there's a clot in there in CT like nobody's business, right? You can see very tiny clots. And then when it contracts, boom, see that? See how small it gets when it contracts? So this person is not in atrial fibrillation. This person has normal atrial rhythm, and that thing really closes down. Let's rotate back. We'll see it here. Goes in, the left ventricle opens up, and then bang, it empties itself right there. That's probably like a 70% ejection fraction or something. So you don't want to start that up if there's a clot in there, you know. Okay. Okay, so that's echocardiography for functional imaging, Doppler, guiding therapy. We saw a whole bunch of things. And then there we saw it for managing whether or not a person has thrombus before doing a therapy. And everybody in the hospital who gets defibrillated is tested for whether or not they have a thrombus first. So they can either go to CT, most of the time they just go to echo because that's in cardiology. And you want those to be good pictures. So now we'll look at ischemia. And ischemia, remember, is when we have the root of the aorta here, and then these two large vessels come off of the root of the aorta. And one is the right coronary artery, and the other is the left main coronary artery. It's coming down here. And the right goes around the top of the right side of the heart, and the left main goes down, breaks into a vessel that goes down the anterior wall, and it breaks into another vessel that goes around the back of the heart. Color map is showing us is what's going on? The default microphone has changed. Oh man. Is it these damn things? I don't want that to happen. I don't know how to unhappen that, but so it says it's recording using these now, which you could screw up the recording, but anyway. Just kill it. Yeah, maybe that's a good idea. Let's kill that there. It should be recording, but it should be recording using the speaker on the computer. So the color map here shows the best guess of which coronary vessel feeds that myocardium blood. Okay, so if I'm looking again, this is called long axis, but this is the parasternal view. Okay, but in the forechamber, so here's my left atrium, left ventricle, right ventricle. And here's that chunk of myocardium that we saw on the echo. There's that horseshoe kind of shape. Basically, the transmitter would be up here, coming down. These blue regions here are fed by the right coronary artery. Okay, it's very rare that any of the blood that is in this muscle here would have come from the left main or the left anterior descending coronary artery. Very difficult to make that happen. So the green here is coming from the LAD, the left anterior descending coronary artery, which is down here, right? And this side is a mix of LAD and circumflex. So this is the circumflex going back around the back of the heart. This is the LAD coming down here. Okay. And when we flip to look at our two chamber, we cut the heart down here, and then this entire wall here is fed by the LAD. As you can see, you don't want your LAD to have the big lesion or have a thrombus go down the LAD and stop it, right? Because a lot of your heart disappears at that point. So all of the green stuff is what would be lacking blood flow if we had a big occlusion right there. And so when you go in, say with coronary CT or with X-ray angiography, you basically look at these main vessels and make sure that they're clear. If you have a big lesion right here such that this vessel gets really small, it's probably a good idea to stent it. Interestingly, if you're not suffering from any symptoms, statistically, it doesn't seem to matter if you stent it or go on the best drugs. You get that choice because statistically, it does not seem to matter, which is surprising, right? I would have thought stenting would save a lot more people. But when you come to the hospital and you have crushing pain and your ECG is screwed up, then for sure you get the stents out, you get ready to open up a lesion. And what can happen is, like, you can go straight to the cath lab and they take a picture and look at it. Or if you're not in super distress and your ECG is still normal, they can take you to have an echo and they'll look at how the heart is contracting. And if, for example, the septum itself seems to have kind of collapsed and isn't contracting well, then there's a high probability that there's a lesion in the right coronary artery, right? Because of that mapping, right? And this is essentially also the spatial resolution over here is what you get in nuclear medicine. So you get these big chunks in nuclear medicine that says, well, I think you get a big blurry lack of signal over here, and you say, well, it's probably the LAD and the anterior wall of the heart. And then there are regions in which it can be either. So here, for example, it could be either the right coronary artery or the circumflex at these boundaries. You can imagine that the best situation would be all of these vessels feed all of the heart. And that way, if one of them goes down, you have the other two. But that's not the way humans are constructed. Turns out that's the way dogs are constructed. They have really good, it's called collateral flow. That means all of their vessels kind of overlap and they get multiple sources of blood flow from different vessels. Humans, not so much. Humans, we just have these. And in fact, when you're growing in utero, this vessel down here on the back of your heart from the right side and the vessel on the back of your heart from the circumflex, they do multiple feed, but then one of them just kind of withers away. I don't know why. And the other animal that has a similar system of collaterals to humans is pigs. So they also are susceptible to dying from a occlusion of a single vessel. You can imagine if you occlude this vessel, which is called the left main, if for whatever reason a thrombus goes in here and gets stuck in the left main, then you've lost 75% of the flow, and usually that doesn't work out. Usually you die. And that's called sudden cardiac death. And remarkably, 50% of people who die from heart attacks, the first symptom that they have a bad cardiovascular disease, the first symptom is that they are dead, right? So they just die. And then afterwards you go in and go, oh my God, they had this large vascular problem. And yet it's still not recommended to screen for heart disease, right? In its wisdom, the part of the National Health Service, not the National Health Service, that's different, of the Health and Human Services here, they don't screen for heart disease, or say you shouldn't screen for heart disease. Now, it's changing a little bit with calcium scanning to determine if people should go on statins, which is a reasonable adjustment of their policy. But they have this recommendation that just normal people, asymptomatic people, should not be screened for heart disease. And then there's this little line in the thing. It says, except for pilots, right? And what was it? Pilots, and there's one other occupation, like firemen or something. And you're like, well, what do you mean? And so it's because in those people, you think it's worth discovering ahead of time that they have a very high risk of dying from a heart attack. I'm like, what do you mean those people? I mean, like, if you want to know if a pilot has a high susceptibility for dying from a heart attack, why should I not want to know that I am in the same situation? Was a pilot more valuable than me? Right? This is in their policy, right? And so they admit, oh, we can tell you whether or not you have a high probability of dying from a heart attack, but we shouldn't do it for everybody because it'll just lead to too much further downstream testing and expense and all of this stuff. So like, okay. But if I'm, on my skateboarder, I'm driving down the 5, who's the pilot now? That's me, right? I got my kids in the car. Okay, so this is called stress echocardiography. It's really an interesting use of ultrasound. And so I've put all of the links to this guy's lecture. He's super experienced on this test. And it turns out that to uncover heart disease in some people, you need to stress them. And so you need to put them on a bicycle, like a stationary bike, and you make them get their heart rate up to a certain level. And then their EKG will change, or the thing that first changes before the EKG even changes is the muscle contraction changes. So if you have ischemia in one section of your heart, say I have ischemia, I've got a vessel clogged here, and at rest it doesn't matter because I get enough flow. But then when I get on this bicycle and make my cardiac output high and the demand high, I can't increase the flow through that little stenosis. And so what happens is the muscle, this blue muscle here, decreases its function. It stops contracting. Just says, oh, I can't do it. It doesn't die. It just stops working. Like it says, I don't have enough energy to do this. And so it just sits there, right, passively. And when you see that, if you can see that, and that's what you do on a stress test, you can watch with echo in real time. And so a stress test, what happens is I start taking echo images. I have in the patient, I have in their decubital vein or something, a line, and then I add a little bit of an agent called dobutamine to their blood. And it's like adrenaline. And so it makes them, like, their contractility of their heart gets really high. And so their heart rate doesn't necessarily get super high, but their contractility gets high. So they squeeze a lot more blood. And it's quite interesting if you're a volunteer in a study and you get this stuff. It's like when you have a flight or fright thing and you look at something and your heart rate goes up. That's what it's like. You're just like something like it's like you're falling in love or something. It's like, ugh. So physiologically you change, but you don't need to breathe anymore, like because you haven't used your legs or anything to get this going. So you crank this stuff in at 15 milligrams, per cc or something for a little while, and then the heart starts beating, and you watch with echo in real time. You see the heart respond, and you see the chamber get smaller, right? And then you put it up to 30, and the chamber gets smaller. Put it up to 45, and it's like boom, boom, boom. The heart is really going for it. And then in those patients where this test is positive, one part of the heart asymmetrically stops contracting. And you just see it and you stop the drug. And you go, okay, we've got a positive test. We saw the muscle stop contracting. And I believe, wait a minute. Oh no, I probably can. Let's see if we can take a look at it. Oh no. Oh, here we go. Right. So this is, halfway. We've put drugs in and we're getting this kind of contraction here. And then we put more and this happens. Right. So you can see this, even though these images are blurry, in the movie, it's absolutely obvious that septum stopped contracting, right? From here. You look there and you say, oh, okay, that thing's moving, it's going well. And here now it's pretty passive and just moving. And so this is a case where you say right here, okay, that's positive. Now we can stop the test. You also know which area the contraction stopped, right? So that's kind of cool. I do like it. Now, it turns out it's pretty hard to do that test well. So you have to have great techs, great physicians, good hospital, all that. So it's not something you can throw into any clinic. You need people who really know what they're doing. Okay. We're running a bit behind, so I am going to jump ahead to this slide, which is an important one. And this is what happens as you get older. Well, at your age, your aortic valve, it's a tricuspid valve, looks something like this, right? It's nice and clean. When it's shut, all the faces are coapted really nicely here. Somebody my age, my aortic valve might look like this. It gets these chunks of calcium, and you can see them on CT. They're there, and but each person gets like little chunky bits of calcium on their aortic valve leaflets. In a young person, when you're ejecting blood, these leaflets open up. You get this really nice orifice, and the stuff goes through without a lot of pressure, right? So your blood pressure is low in that you can just squeeze the blood out with low pressure. But in an old person with this, the valve is stiff and it only opens up to a certain amount. And so you need to generate higher pressure to get blood faster so that in one beat you get as much blood as you need, right? So what happens to your heart usually is here's the nice healthy aorta and here's your left ventricle happily contracting. And then in this crappy old aorta where you've got all this calcium here and just this tiny hole, the heart becomes completely beefed up because it has to push harder and harder. And so this is called ventricular hypertrophy. The people who get ventricular hypertrophy are old people with this condition or Olympic rowers, right? Or Olympic runners. So when you do a lot of cardiovascular, like high-end cardiovascular for hours and hours, you'll get hypertrophy of your left ventricle. However, it's kind of a healthy hypertrophy for most people, right? Say that again.
The that can be stored inside.
Yes.
So that would reduce.
Okay, so the question is, does your end diastolic volume, the blood that you have to start the ejection, does it change as this hypertrophy gets bigger? And yes, it does. And so your heart can get smaller. The chamber can get smaller because of the increase in the muscle. So then what has to happen? You have to increase your heart rate, right? So your heart goes faster to get the same cardiac output, right? Say it again. Well, that's a great question. Is a lot of cardio therefore not good for you? Anything that is done to excess is probably likely not good for you. However, not doing any exercise is also not good for you, right? So you have to find that happy balance of just challenging the system and stressing it such that it knows how to recover from stress and does so well. So, and in fact, people have shown life expectancy to increase significantly, measurably significantly, just by walking 500 meters a day, right? You don't have to run 25 miles. In fact, your life expectancy might start going down if you start running 25 miles a day. But just getting up and walking just to get your circulation going makes a huge difference. So it must be some kind of humoral thing, but okay, that's aortic regurgitation. It's a bad thing. This doesn't look too bad. Look, this is two little dots there. Okay, we've come to the end. Great. So that's echocardiography. It's claimed that it's less expensive than CT, but it isn't. Like because you need a really skilled tech and it takes 20 minutes and stuff like that. So billing for both those things is about the same. If CT is a bit cheaper, actually. In fact, CT is too cheap. MRI is more expensive than either of those. A cardiac, as we'll see, exam takes about an hour, right? Echo probably takes about a half hour. Then a physician has to read it. It takes the physician probably 10, 20 minutes to read it, maybe 10. So they can only do 6 readouts an hour, so that those are all expenses that add up. So it's not cheap, The machines themselves can be super small. There are machines, I kid you not, looks like this. You do this, the thing's here, and you watch on your phone, right? That's pretty cool, right? So that's the cheap end, and the expensive end, they're about, $400,000 to $500,000 with all of the signaling bells and whistles inside, right? So looking at like projects, if anybody wanted to do a project on Echo, one thing that it would be great to have somebody do is a really deep dive into fully 4D echo, modern 4D echo, where you use a phased array transducer that essentially broadcasts a plane of ultrasound into the sample and then receives, this 2D by time signal back to reconstruct the 3D image and 4D image in real time from that entire signal. Because that's traditionally what you did was you did a slice, click the slice, another slice, click the slice, another slice. But now they have big transducers that'll do the whole thing.
What you just showed me.
Yeah, yeah, exactly. They look beautiful, right? They're really nice. Okay, great. A reminder that by midnight, the first homework is due, and you just call Diana or email Diana if there's something unfamiliar with how to submit it. And that's it. Okay, see you on Monday.